Um, so welcome. My name is Sydney. I'm one of the nurses with the neurology clinic at Sick Kids, with history on 5C neurology and neurosurgery. Here with my colleague, Caitlin.
Hi, I'm Caitlin Flynn. I'm one of the clinic nurses in the neurology clinic, and I work as the epilepsy nurse navigator for the epilepsy surgery program. And as Sydney mentioned prior to that, Sydney and I were both inpatient nurses on the neurology ward at Sick Kids. So we have quite a different range of experience dealing with children with epilepsy from the acute side to the chronic side. And we just wanted to share some of our experience with you all today. So Sydney's going to start us off.
Excellent. Thanks, Caitlin. So we will have time for questions at the end as well. So if you could wait until the end to ask questions, that'd be great. But we're going to do our best to kind of cover all the bases, going from just kind of general information about seizures and epilepsy to treatment and intervention from a nursing perspective. Just video. First and foremost, just what is a seizure? And I imagine most of you with a nursing background have gone over this many times before, but ultimately a seizure is an electric disturbance in the brain, typically a burst of uncontrolled activity, electrical activity between brain cells, meaning neurons, nerve cells. This causes an abnormal and excessive electrical activity in the brain that changes the way that the body functions, causing temporary abnormalities in muscle tone, movements, behavior, sensations, or states of awareness. And the presentation of the seizure can vary, and it's determined by the location of the disturbance and how much of the brain is involved. There's many different presentations that you can see. Some children will have more than one presentation changes over time, and they can last from seconds to minutes, and even longer when it comes to something like status epilepticus. And then what is epilepsy? So epilepsy means two or more seizures that are unprovoked, or one seizure that is accompanied by a high risk disease. So they have a predisposition, such as like a genetic predisposition for seizures, as well as abnormal electrical activity in the brain, and it is a neurological disorder. And underlying conditions can be genetic diagnosis, structural causes. So we think of lesions, tumors, those kinds of things. So epilepsy in children, which is where Caitlin and I, it's our main focus. I mean, epilepsy can affect any person at any age. So the onset is not necessarily pediatric. About 70% of epilepsy is controlled with medication alone. Drug-resistant or refractory epilepsy, intractable epilepsy, means that they've tried and failed at least 2 medications with little to no seizure control. At that point, there are other types of interventions or treatments, such as diet, surgery, or medical devices, such as VNS, DBS. We'll elaborate on those a little bit later. Some patients, some children might be well controlled on one medication, monotherapy. Others, it can be quite a journey to try and accomplish control. So possible causes of epilepsy, genetic conditions, that's something that typically we investigate with some of our patients, and they have a predisposition to epilepsy. Traumatic brain injury, or TBI, or head injury in the past that results in seizures, a brain structure abnormality, HIE, so lack of oxygen during or shortly after birth, so hypoxic ischemic encephalopathy. Stroke is one, brain tumors, central nervous system infections such as meningitis or encephalitis. We see a lot of seizures following those diagnoses. Underlying metabolic disorders, and there's also just idiopathic causes, so unknown causes as to why the seizure started. Getting into the types of seizures, one thing I want to say that we often say to parents and teachers when we do teaching is um, we're less worried about the actual terminology and definition. The main focus is, can you describe the seizure, what it looks like? And we say this because the terminology changes all the time. The more important thing to be able to is to be able to describe the seizure, not necessarily knowing exactly what the definition is. There are two main types of seizures, or two main subsets of seizures, generalized and focal. And I'm sure you've heard those terms thrown around a lot when it comes to epilepsy. And going into like focal and generalized, those are also have subsets of aware versus impaired awareness, motor and non-motor. Generalized seizures are impaired awareness, and they also have motor and non-motor seizures, and there are seizures of unknown onset as well. So we'll go further into that. So starting with focal, meaning that it starts in one area of the brain, but it has the potential to spread across the brain, causing mild to severe symptoms depending on how the electrical charges spread. So what matters is where in the brain the focality is, and how far it travels. Focal seizures can also change into generalized seizures, or if they spread in such a way. There's focal aware and focal impaired or unaware. With focal aware, their children are awake and aware during the seizure, and unaware meaning that they're not awake or responsive during the seizure. The other terms for that are simple partial, so focal aware being simple partial, aware of what's going on and may notice unusual sensations or movements. Whereas with focal aware or complex partial, it can cause altered consciousness. They're not aware of what's going on around them and might not remember the incident happening. And this typically happens if abnormal activity is involved in a larger portion of the brain than in the simple partial or focal aware. Tends to be more localized to one region. And then just taking a look at the other factors, so motor, meaning that it's involving parts of their body, automatisms, atonic versus clonic, spasms such as infantile spasms, hyperkinetic, myoclonic, and tonic. We'll get into that a little bit more in a bit. And non-motor, including things like behavioral arrest. That's another term that gets thrown around a lot, meaning that they just simply stop the activity that they're doing. Autonomic, cognitive, emotional, and sensory. And then focal has as I mentioned, has the potential to change into a bilateral tonic-clonic event. So moving on to that, the motor, we tend to see tonic, which is rigid muscles. The clonic portion could be rhythmic jerking of limbs. There's tonic-clonic. Atonic is when you lose tone. Muscles, limbs lose tone, they become limp. Myoclonic is sort of a brief muscle twitching, almost like an electric jolt, which can cluster. Automatisms, like lip smacking, hand rubbing, repetitive motions, and non-motor, the behavioral arrest, which I mentioned, abruptly stopping what they're doing. This can just last seconds. A change in emotion, a change in cognition, or a change in autonomic function. And with that, we might see like loss of bladder control, but also changes in blood pressure, heart rate, or other such. And then getting into generalized seizures, which I think we see and hear about a lot more in terms of when we talk about epilepsy and the way that it's presented in society. With generalized seizures, they can start as a focal seizure that spreads to both hemispheres of the brain, or be of generalized onset, which means that it starts simultaneously in both hemispheres. And these are a bit more specific in that they have motor versus non-motor. And the important terms or things to notice in a generalized seizure are tonic. So the rigid muscles, they stiffen, lose loss of consciousness, eyes might deviate or roll back into the head. Contracting of muscles in the chest makes it hard to breathe. So that's where you might see the change in color, cyanosis, or just gray and ashen. So they can stop breathing. Sometimes it's not that they've completely stopped breathing, it's that their breathing is just so shallow that they are not getting enough oxygen. And there might be gurgling while struggling to breathe. The clonic portion is what causes a person's muscles to spasm and jerk. Um, the elbows, legs, and neck flex and then relax in rapid succession. Um, as a seizure starts to dissipate and slow down, you will see the jerking lessen and slow down as well. So then a tonic-clonic seizure is those two movements occurring simultaneously. So the tonic, so the rigid muscles, and the clonic, which is the rhythmic jerking of limbs. Atonic, also commonly referred to as drop attacks, is when they rapidly lose tone in their body, become limp. And this is where sometimes we see kids being very prone to falls and head hitting because they might just be going from standing or sitting to a position of falling right away. And myoclonic jerks being brief muscle twitching, again, like kind of like a jolt going through their body. And non-motor generalized seizures, kind of going into absence seizures, staring spells, and myoclonus. Triggers differ from person to person. Some people might have some very obvious triggers, others may not. Missed doses of medication, especially if there's subsequent doses of medication missed, is an obvious trigger. But others to keep into consideration: poor sleep hygiene or sleep deprivation, stress or excitement, which obviously, looking at a pediatric population, their definition of stress would differ probably from yours and mine. They might not have work stress, but the stress of, we see it a lot when school starts. They change their typical day to day, and that's the stress and excitement that can actually provoke seizures. Illness, so we see a lot of kids who have more seizures when they're sick. Um, we do see kids who almost every time they're ill have a seizure. That sort of differs from just febrile seizures though. So a heat and increase in body temperature, as well as hormonal changes. So at the onset of puberty, um, we might see a change in seizures. We sometimes see kids who are seizure free, but then at the onset of puberty might start to experience seizures again, or a change in seizure activity presents differently. And in females, a correlation with menstrual cycles um, is sometimes common. Flashing lights is another one that I think we all commonly think of. There are other triggers that might differ from person to person. And it is really important to kind of note those triggers. We often ask parents and caregivers, teachers, to make note of those. If there's any kind of obvious correlation, so that maybe we can try and prevent those things. And now getting into treatment. So we talked about medication. We're going to go further into surgery, dietary treatment such as a ketogenic diet, and medical devices. Um, Overall, response to medication for seizures, 50% will achieve seizure freedom with monotherapy, so meaning the use of one anti-seizure medication or anti-epileptic drug. 15% will require a second or third anti-seizure medication, and the remaining are considered intractable. So once we've sort of trialed 2 or 3 medications, we tend to start to look at other types of therapy. One of those being one that I work closely with is the ketogenic diet, and I'm sure in the community you hear about that as well. It is a strict diet, very high in fat, low in carbohydrates. There's different forms of the ketogenic diet, but ultimately, the ketogenic diet causes your body to create ketones. And while in a state of ketosis, in some children, there's a notable reduction in seizures. The actual mechanism of why this works is actually not known. It's not effective for all children. It's very strict and challenging to adhere to, and it's costly. If you're caring for a child who is on the ketogenic diet, um, you probably have very strict dietary like times that they have to eat, amounts that they're allowed to eat. Um, and for some kids, I've seen kids go completely seizure free. I've seen kids just have, somewhat of a reduction in seizure or um, just a reduction in general. But I've also seen children who remain on the ketogenic diet simply because they're more bright and alert while they're on the diet. But it's not for everyone. And it affects not only the child, but the family because it's quite a devoted measure and it's quite expensive. So I'm going to hand over to Caitlin while we go to the next slide.
So I'm just going to take over sharing my, oh, Sydney, I think you just have to stop sharing and then I can take over. Perfect.
Did that work? Okay.
Yeah, wonderful.
Perfect.
Okay, can everyone see my screen? Perfect. So another factor that we think about when a child becomes drug resistant in regards to seizures is surgery. Is there any kind of uh, resection or disconnection that we can do to stop the seizures from happening? So there's a couple things we have to look at when we are considering surgery for a patient. So the first is we have to have one specific area of the brain that the seizures are coming from. If the seizures are coming from bilateral sides of the brain, that's not a resective candidate. The other thing we have to look at is the area where the seizures are coming from. If we were to remove that area or disconnect that area, are we going to cause any damage to that patient? So if it's in a motor area, if it's in an area where it affects their speech, their ability to understand speech or to have speech, their memory, cognition, like those are things we don't want to touch. So we do a lot of investigations when we're working children up for epilepsy surgery to make sure that we know that all the seizures are coming from one spot and we're not going to do any damage to that child. For children that are drug resistant to medications but are not a candidate for resective surgery, either they have a bilateral seizure focus, then we start to look at medical devices. So this is a newer area that's coming up and we call it neuromodulation. So the most common one that you might see in the community is called the vagus nerve stimulator. So this is a medical device that's placed in your chest and it has a pulse generator, and then a wire goes up and connects to your vagus nerve. And what happens is it delivers pulses of electricity to your vagus nerve. We again don't know the mechanism exactly for why this helps. But for some children, this can be effective in reducing the number of seizures, and it seems to work really well for those bigger seizures, so those generalized tonic-clonic seizures. The VNS also comes with a magnet that you can swipe if your child is having a seizure. So a lot of times when I do teaching with the schools, I really emphasize that this is a great device because you can swipe it at seizure onset and every minute. So for schools, it gives them a chance to do interventions without having to do medications right away. Another term you might hear about in the community is DBS. This is deep brain stimulation, and we've started using this for some seizure control. Often patients who get a DBS have been investigated for a VNS first. So now getting into more of the practical side of epilepsy and what you are going to be looking at in the community. So in terms of seizure assessment, one of the things when we're talking to parents is we want to get a good history of the seizure. So we want to know, when did the seizure start? What did it look like? How long did it last? How frequently have their seizures been happening? As Sydney mentioned, we always ask about triggers because if it's a seizure that's out of the blue, but they have a fever, that gives us a little more of a rationale for why the seizure was happening versus an unprovoked seizure. So there's a couple stages to a seizure. So prodromal is a stage you might not have heard of. Not every child has this. It's only in about 20% of cases, but this can happen hours or days before the seizure. So in some of our patients, parents might say they were acting a little bit off. I could sense something was coming. So that's always just good to be aware of if you're dealing with patients that have a prodromal stage. If parents note that something kind of changes in the days or hours leading up to a seizure. An aura, again, not something that every patient has, but if they do, it's very helpful because from a safety standpoint. So, an aura could be something like they get a strange sensation, or they smell something, or they have a funny taste, they have a tingling sensation in part of their bodies. And so, for children that are cognitively aware enough to tell you if they're having an aura, that can really help prepare you because you can put them in if they're standing, you can guide them to the ground. If they're in a chair, you could get them out. Like, so you can start thinking about safety a little bit more before the seizure. The ictal phase is the actual seizure itself. And then the postictal phase. So, this is how the patient is after their seizure. So, for a lot of patients, they might be confused, they might be lethargic, they might have a headache, they might be tired, they're not quite back to their baseline. And the reason we emphasize this is one thing that we find in the community, and especially with parents as they're getting used to their child's seizures, is sometimes they can have a hard time distinguishing between these phases. So we've had families that have actually been included the postictal phase where they're tired and not back to themselves, but they're actually out of the seizure. And so that's really important because when you think about giving medications, and if the seizure is only 3 minutes and the rescue med is 5, but they're tired for 5 minutes afterwards, we don't want someone thinking that that whole seizure is 10 minutes. We want them to be able to recognize, okay, now they're out of the seizure, they're just really tired afterwards. So the main thing we always say to care providers and parents and teachers, stay calm, because I know it's very stressful when you have a seizure in an area that's outside of the hospital. So you want to try and stay as calm as possible. It's really helpful to start timing the seizure. We all have a phone. We all have phones now, so we all have a stopwatch on our phones. So I say start to time as soon as you can. For motor seizures, those bigger seizures, if they're in an area like a classroom setting, you want to move like chairs and tables away. We don't want them hitting a body part, a limb, or their head on anything. If it's safe to do so, say someone was standing and starts to have a seizure, try and guide them to the floor or to a stable surface. So if they were on a bed, that's a safe surface, but you want to make sure they're not going to fall off the bed, things like that. If it's possible to do so, put them into the recovery position. We do know some children can have vomiting with seizures, either during the seizure or immediately after the seizure. So, if it's safe to do so, you can put them in the recovery position. For some children who are in the middle of a big generalized tonic-clonic seizure, that might not be safe to do so during the seizure, but you might want to think about that as soon as they're out of the seizure. And then rescue medication, we'll talk a little bit about it, but either most of our children at school have a seizure protocol plan. And if they are prescribed a rescue medication, it has parameters for when it's safe to administer that. And then we'll talk a little bit about calling 911. Normally, this is a discussion we have with our families about when to call. For non-motor seizures, so something like, say, an absent seizure where you might have a child who is staring, or a behavioral rest seizure where they just stop what they're doing. Again, we just want you to remain calm, time the seizure, and depending on the rescue medication parameters, you may have to administer or not. But these are a little bit less intense of a seizure to deal with in the community. So, rescue medications, the point of rescue medications, we hope that it will stop the seizure. We try not to use these We do not use these for every seizure. These are for prolonged seizures or for clusters of seizures in certain cases. So the child's neurologist will always put parameters on their rescue medication for when they should be administered. And so this is something that if you're dealing with a child in the community, the parents should be aware of, the school should be aware of, the nurses should be aware of. So the most common rescue med that we most often prescribe is lorazepam, also known as Ativan. So it's a benzodiazepine or a CNS depressant. In pediatrics, everything is prescribed based on a child's weight. So you might see a dose. It comes in zero. 0.5, 1, and 2 milligram tablets. So you'll see a variety of different doses depending on the child's weight. Um, the most important thing with this medication is it is either administered sublingually, so under the tongue, or buccally in the gum or cheek pocket. What we often recommend to parents is to administer it buccally. So there's a couple reasons for this. It's really hard if you've ever had to try and administer Ativan to a seizing child, especially a motor seizure where they're moving quite frequently. We don't want anyone to get bit, which can happen. There's often also a lot of drool. So we've had some parents that think they're putting it under their tongue and then it drools out. So often what we say to families is the best way, and I teach this to schools, is to give it buccally. So either to rub it into the cheek pocket, or what I often say is to rub it along the gum line where you can get some friction. It does not dissolve instantaneously. It does take a little while. It can take up to like 30 seconds. So we keep we that I think sometimes parents think it magically dissolves, and we have to emphasize to them that you need to use a little bit of friction, and that it won't dissolve right away. We do always say to parents, if you swallow the sublingual tablet, it's not going to be as effective because we know that anything swallowed, it's going to take 30 to 45 minutes to take effect. So it's not going to be as effective. After Ativan administration, the most common side effects that you'll see are drowsiness, dizziness, sedation. Plus, that coupled with that postictal phase, you might have a child that is really, really tired. The other medication that we often prescribe, and this one, we often go to midazolam if the Ativan hasn't been effective, not because it's um, not effective, but just because it's a little bit more challenging to prepare. So unlike Ativan, which comes in a tablet form, midazolam comes in a in a vial, and you have to draw it up with a needle. So a lot of times parents or schools are a little bit intimidated by this because they're not used to regularly drawing up medication. Um, so the dose will be prescribed. Most midazolam vials come in a 5 milligram per mil vial, and they're administered with this mucosal atomizer device, or we call it a MAD device. So the MAD devices all have a dead space, and so typically it's zero. 0.1 cc's, but it's always good to check the MAD device that the patient you're caring for has because it can vary. Some are 0.05. So what you're going to do is you're going to drop the amount in milligrams or mils of midazolam, plus add that extra zero. 0.1 or zero. 0.05 um, with your needle, and then you're going to switch and it lure locks out onto this MAD device. And as you can see in the photo, it's like a soft white, um, it's very squishy, and you're going to put that to their nair and then plunge really forcefully. So the reason you're pushing really fast and quick is it atomizes and it makes this mist that goes up and then is absorbed into the mucous membranes. What will happen if you push it really slowly is it's just going to drip right out of the nair and it's not going to be effective. Um, the one thing to note with this is if the dose is over 1 mils, which you typically would only see this in bigger child, often then we'll recommend splitting the dose because we only want to give 1 mil of midazolam per nair. And again, as midazolam is also a CNS depressant, it can cause drowsiness, dizziness, impaired awareness. Things in terms of practical storage, it's not refrigerated, so it can be kept at room temperature. So it's great for schools in that way. The unfortunate thing is once you've so if you've drawn it up to administer and then the child stops seizing, you can't reuse that drawn up bit. The vial, once it's open, it has to be thrown out within 28 days. And we want to store it in like a clean, dry place away from sunlight, obviously out of the reach of children. A lot of our families do reuse the mat and the syringe at home. They can rinse it out and reuse that. In the hospital setting, it's a one time use, but at home, we know that supplies are expensive, so it can be reused. So, now getting into when to call 911 for seizures. So, I think the most important thing is you want everyone to be comfortable with what's happening. So if it's a first time seizure, a child who's never had a seizure before, that's an instance where you're going to call 911. If it's a presentation that is completely different and the child's never had, so say it's a child who has um, absence seizures and then all of a sudden they've had a generalized tonic-clonic seizure, that would be a case in which you'd want to call 911. If you've administered a rescue medication for the first time, so if they've never received Ativan or midazolam before, we often recommend that parents or teachers or community members call 911. Or if you've administered the rescue medication and the seizure is not stopping. We often say to schools, we want you to try one time. And if that's not working, then we want you to have help before they administer a second dose, because we know that benzos can have an effect on the respiratory system. So, cyanosis, shallow breathing, those are things you want to think about if they're having to give multiple doses of benzos. Another reason we call 911 is if they're starting to cluster and they're not coming out of the seizure. So they're having a seizure, coming out of it, and then going right back in, and they're not returning to baseline and they're starting to get closer and closer together. And obviously, any injury, if they have an injury from the seizure or if the seizure occurs in water, those are serious events that we want to think about. So, one thing we often talk about in terms of seizure safety with our families first is water safety. Um, so, not even just swimming, but things like being in the bathtub. We know that seizures can happen really quickly, and we want someone to be aware. So, what I normally say to my teenage patients who want privacy is to have compromise, like to make sure that someone is aware that you're using the shower. Um, it sounds silly, but it's really important for them to, for families and patients to be aware of how quickly things can change. Um, Obviously, rescue meds, they're benzos, so we want them to be safe. So we've had a lot of conversations with a lot of families will make like a medication pouch. But one thing I talk to about families is you want to make sure that if a child has Ativan at school, that it's out of the reach of other children. So we often recommend that it either be kept if the child has an assistant in the classroom or a nurse in the classroom, it be kept with them, or it be kept in the office. So you just want to make sure that these Ativan tablets are out of the reach of other children. Re- expiry date is also important. Most of these medications expire after a year. Um, they may be a little bit effective, but that's not something we like to take a chance on. So we always try and tell our families to make sure that they're getting new rescue medications at the start of the year to bring to school. And then finally, SUDEP, um, which is a awful topic that but it's a hard conversation we have to have with our families. So SUDEP is sudden unexpected death in epilepsy. This happens to about 1 in 1,000 individuals with epilepsy. We don't know the cause. It's not caused by drowning or injury. It typically happens during or immediately after a seizure. And we know that kids who are at risk for this, it's often kids with uncontrolled seizures, those bigger generalized tonic-clonic seizures, frequent seizures. So we always ask them to like take extra pillows and blankets, things things very similar to like when you have a baby. You don't want extra things on their bed. And then just other things to consider when you're dealing with children with epilepsy. You want to think of their level of development, both physically and cognitively. So, a patient who's in a wheelchair or has a trach, um, they have other comorbidities that are going to make it a little harder to guide them to the ground if they have a seizure, versus developmentally and cognitively. We see children who have epilepsy who have no other comorbidities, and they might have an aura and be able to tell you they're about to have a seizure, and it's easier to manage versus other children who are maybe nonverbal, or can't convey that they're having a seizure. You have to kind of learn their signs and learn what to expect. Um, Another thing to think about is, does your child that you're looking after have a long history of prolonged seizures or status epilepticus? We have some children that have seizures, but they've never had a big generalized tonic-clonic seizure, or they've never had a prolonged seizure. Some families have never had to use rescue meds for their seizures, whereas we know other children, they could secondary generalized, so as Sid said, go from a focal to a generalized seizure, or they have a history of when they do have a seizure, it's going to be a big seizure and you're probably going to have rescue meds. So just to prepare yourself for what their seizures look like in the past, so you know how to deal with them in the future. And then these are a few good resources. So, About Kids Health, which is our Sick Kids education page, we have a whole epilepsy learning hub that has information on different meds and how to administer midazolam and lorazepam. There's a good midazolam YouTube video from Sick Kids that I highly recommend. It has like the step-by-step process of how to draw everything up. Epilepsy Canada, Epilepsy Ontario, and there's actually Epilepsy Toronto. They have really good practical things, to talk about, like epilepsy and driving, epilepsy and alcohol use, things that we talk about with our teens. Um, John Hopkins Center for Disease Control, and then also I'd really plug the International League Against Epilepsy. This has all the new terminology and classifications. So if you're ever unsure about something with epilepsy, they're a great resource to go to because they have all the up-to-date information. And I think now I'm going to stop sharing and we'll answer some questions.
Feel free to type any questions in the chat too. We've got one in the chat. Is the keto diet long-term?
So I'll let
Yeah.
Sydney take that one over because she's our nurse for the keto program here.
So that's a great question. It can be. So the keto diet, it can be long term. We have kids who start at a very young age and they achieve great seizure control, better cognition, things like that, and they stay on it for a very long time. There are other kids who might start on the keto diet. They might stop because they don't gain any kind of control, or they stop after a while, similar to a medication. I always say that the keto diet is like a medication. So after, several years, depending on the physician or the team that you're working with, usually it's something like 2 years of seizure freedom, we consider weaning off of a medication. It's similar in the keto diet. We look at it from all perspectives. So what does their EEG look like? Do they have like a genetic background or predisposition? They would consider weaning off of the diet, or if it just becomes kind of too much for the family or the child to adhere to.
And then maybe just to piggyback onto that, Sydney, someone has asked, if the keto diet creates ketones, does it affect blood sugar? So I'll get you to answer.
Yeah, so it does, it can. When we're starting them on the diet, we actually are testing both things. So for the two most common forms of the keto diet, we actually admit them during this time. We're measuring urine ketones, blood ketones, and blood sugar, just making sure, obviously, that their sugars aren't too low. If they are, we treat with apple juice or orange juice. We only do this while we're establishing the diet. With that being said, throughout the duration of being on the diet, if they become sick or if there's any indication that they might have low blood sugar or high blood sugar, we recommend that the families still test and treat. So it's something that we teach the families and their caregivers. They have like a guide on what they should do in order to treat low blood sugar.
Okay, I'm gonna answer one of the general questions, and then I see another one for Sid. So I see when you say 3 seizures in 30 minutes, how long does each episode have to be? So this is a specific parameter that not every child will have. Often, so for instance, some children that have those non-motor seizures, we might not put a cluster in as their parameter because we know they might, some of my patients have maybe 10 absence seizures an hour. So though for those children, we're not going to want to give them a rescue med because they're going to hit this parameter every time for that. Whereas someone who might have tonic seizure, so big stiffening, so like right-sided arm tonic, those ones we might say 3 and 30, and that would mean 3 of any length. So I think the most important thing when you're working with these families is to make sure the parameters on their rescue medications are really clear. So we even have to do that work with our neurologists. A lot of times our neurologists are getting better about putting, if there is a cluster parameter, so 3 and 30, a lot of our kids have multiple seizure types, so they'll put specifically like 3 tonic seizures within 30 minutes, not for absent seizures. So they'll be really clear about that. So I think that's the thing to emphasize if you do have a parameter for a cluster of seizures, that it's really clear about what type of seizure you can administer that for. And then another question I'm just going to ask, are febrile seizures caused by a fast spike in temperature or just a high temperature in general? Generally just a high temperature in general. So children can have febrile seizures and not be considered a patient with epilepsy. So we kind of keep that separate. But we do know that for our patients with epilepsy, that's one of the first questions I ask when I get a call from a family. My families start to answer my questions before I even ask them. They're like, no, they haven't been sick. No, their sleep was fine. No, there hasn't been any stress, because we know that children with a fever can have breakthrough seizures or an increase in seizures. And then I'll do this VNS magnet question, and then I'll hand the keto ones over to Sid. So when to use the VNS magnet? Is it as soon as we see a focal seizure? Yes, VNS magnet. The one thing I always say to teachers and providers, use it right away. You're not going to hurt them. So the VNS device actually has a background setting that goes off typically it can vary, but typically every 5 minutes it's going off in the background. So we have a background setting that's going. It also, the newer models have an auto stim. So if all of a sudden there's a very quick spike in heart rate, it goes off. And then of course the magnet use. So what I say to teachers and providers is if they're having a seizure, swipe it. You're not going to harm them. They're used to the current going off in the background. The magnet is a little bit higher, but if you see a seizure and they have a VNS, use the magnet. And then I'll pass some of these keto questions over to Sid.
So looking at if a client has been on the ketogenic diet for too long, does it eventually stop working? I don't have an absolute answer for that, but similar to being on certain medications for a long time, it may eventually like kind of exhaust the resources. But with that being said, I don't think longevity is necessarily a factor. But we change the diet as things go on. So there's a thing such as a ratio, and they might be on like a 2-to-1 diet or 1.5-to-1 diet. We change the ratio of how many carbs they can have essentially. And it's similar to medications in that we might have to play with doses, in particular with children, because medication doses are weight-based. So similar to that, the ketogenic diet, we try to find like that sweet spot in their ketosis. So when we measure their urine ketones, we look for, somewhere below 16. 16 is pretty high, but usually kids have kind of like a sweet spot. So I wouldn't say that for being on it too long, it eventually stops working. I just think that it might not be for them. And then another question, how soon after stopping the keto diet do seizures usually return? Wondering if children are able to have a cheat meal. No. So in the ketogenic diet, it's not like the keto diet that we talk about for weight loss in, which a lot of people think of right away. There's no such thing as a cheat day, cheat meal in the keto diet, because ultimately they can pretty quickly come out of ketosis, and it's like taking away a medication. Now they are suddenly at high risk for having a seizure. Great examples. This sounds heartbreaking, but we have examples of finding a child that tried to sneak an apple, and as a result of eating said apple, had a seizure, or more seizures rather, and it was a pretty distinct correlation. So yeah, no cheat days.
Okay, I have a similar story about a child sneaking birthday cake and being admitted for status
Yeah.
epilepticus. So is epilepsy an umbrella term for any seizure disorder? Yes. So epilepsy is kind of like the big umbrella term, and then we break it down. Obviously, there's different syndromes for epilepsy. There's genetic causes for epilepsy, but an epilepsy, as Sydney mentioned in the beginning, you have to have 2 or more unprovoked seizures. Um, and then can they feel the current for the VNS? So generally what we do after we insert a VNS is we start at a really low current and then we start to titrate up. So we can stepwise titrate it up until we get to level where their seizures are controlled. Um, most children can feel the current. Eventually, it doesn't really bother them. The one thing we often do note with the VNS, so you can have a change in your voice, so it can sound a little hoarse. Sometimes they might cough when the VNS goes off. So we want to get it to a stage where it's working effectively for their seizures, but we also want them to be able to tolerate it. So if it's going off every 5 minutes and it's just too much, it's uncomfortable for them, or they're coughing all the time, then we might look at turning it back down again. So it's kind of, as Sydney was saying with the keto diet, it's something we kind of adjust as we go along. I think we've addressed all of the questions in the chat, but I just want to make sure that if anyone else has any other questions, we're happy to address those. I'd also be curious, I know we sometimes deal with community nurses. We do a lot of teaching with schools, but what are the challenges that people in the community are experiencing with children with epilepsy? Is it a lack of awareness around epilepsy? Is it fear about when to use the medications? It's helpful for us as the clinic nurses to get a sense of like what the challenges you guys are dealing with in the community. So if anyone, okay, someone said, could you talk a minute about palliative care with progressive epilepsy? Yeah, so I think that's one of the most challenging things. We don't necessarily give up on any of our patients. Um, Something I have a lot of conversations. The patients that we see with epilepsy are often the really severe cases. So there's always new meds coming on the market. We keep trying them, even though, as we said, once they're onto their 3rd medication, they're normally considered drug resistant. We keep trying. Um, so we'll keep trying different meds. Certain medications are better for different types of seizures. So we try different combinations. We increase the dose as much as we can. We keep working on that. If they're a surgical candidate, we work them up for that. If they're not a surgical candidate, then we do look at things like VNS, DBS. Once they're at the point where, you know, they've tried a bunch of meds, VNS, DBS, it's kind of the end of our line, but we still keep trying. So there's always new meds. There's meds coming in from the States that we're doing clinical trials on. There's new neuromodulation devices that are starting to be approved for Canada. So something called RNS, we're starting to, it's done in the States and we're hoping to get into Canada. So, the medication, there's always new medications coming out and there's always new technology coming out with neuromodulation. So, we try to give hope to families that we're still, but we know it often depends on the cause of their epilepsy. So certain genetic diagnoses or syndromes, we know that they're going to have terrible epilepsy and likely nothing is going to help it. And for those cases, I think it's really important we get our social worker team involved. We have palliative care through the hospital, or PACT team, Pediatric Advanced Care team, and we get them involved and we start thinking about, medical directives, do families want CPR? Do they want life-saving interventions? Like those are important conversations to have. And I think, we know that those kids are also the ones that are really high risk for SUDEP. So I think it's a lot of hard conversations and just talking about what families are comfortable with. But we don't give up. We keep trying.
Yeah, to add to that, like some kids we know just will never be seizure free or are very unlikely to be seizure free. So trying to kind of find a baseline where they're comfortable is sort of a better goal to have, and to be realistic with families, that even with interventions such as VNS or keto diet, we may never achieve seizure freedom for a very long time. So just being realistic and having that realistic expectation, sadly, is something that we have to do. Seeing this question or this comment rather, challenges in the community is support staff in the school, panics when they witness seizures among students. So we usually support them to calm themselves down and educate what is a priority during episode, which is safety. So I just a comment on that. We hear that a lot as well. I think they panic in terms of things like using the VNS, giving the medication. Some people, when we do school teaching, some teachers, staff, they've never seen a seizure before. So that panic, it's panic provoking for sure. So keeping everyone calm is definitely the priority. I had a child with a genetic disorder that could have hour-long seizures, even with rescue meds. Never saw him have a seizure. But what do you do for a child that is seizing for over an hour? Do you just monitor and wait? So, I mean, I'm definitely familiar with that being, so that's essentially status epilepticus. And sadly, we do see kids who, when they seize, they really seize. Those are ones where they might have to be admitted for more than just the abortive therapy that we can offer in an outpatient setting, in the sense that, uh, Ativan and Medaz, those aren't going to do it. They might need to come into the hospital for IV, like IV, like Keppra, like IV intervention. Sometimes they end up basically in drug-induced comas to try and give their brain a break from having those seizures. But if that is their norm, their baseline, I think that's a conversation that you would have to have with the neurologist, like the team and the family. Are we hospitalizing this patient every time that they have a seizure? It depends, I think, on the frequency, but it is definitely very dangerous to be seizing for over an hour. Sadly, if that's their baseline, I think it is still important to consider hospitalization, of course, because in a home setting or school setting, obviously, you don't have things like oxygen necessarily, oxygen or the ability to establish an airway. And that would be one of the big concerns. Caitlin, I don't know if you have more to add to that.
Yeah, I think the one thing I would add for that, it's not common to have an hour-long seizure. Most seizures don't last that long. So a lot of conversations we have with families, some families can administer, so say they have an Ativan 2 mg rescue med for a seizure over 5 minutes. A lot of times if it's a child that we know has longer seizures, we might put can repeat second dose after 5 minutes. A lot of our families sadly become really comfortable with giving the second dose at home. It's not typically something we expect schools to do because, as I say to teachers, I was like, we know you're not a healthcare professional, so we want you to try and stop the seizure, but we don't expect you to start getting into the weeds. But again, an hour-long seizure, unless there's been a conversation with their healthcare provider, that's not the norm. And we'd probably at that point be telling family to bring them to call 911 or bring them to the emergency department, especially if it was a motor seizure. Another thing we didn't touch on in our presentation, because it's a little bit separate, but there are also things called PNES, which are psychogenic non-epileptic seizures. And those tend to be very prolonged. I don't know if anyone's dealt with them in the community, but there are seizures that when you do an EEG, there's actually not an electrical change in the brain, and it's a body's response to stress and anxiety. And we saw that a lot during the pandemic. It's not something that the patient or child can control. So that's something we also think about with some longer seizures, because hour-long seizures are not typical. That would be either status or something like PNES. Someone asked me, a child experience both types of seizures, focal and generalized? Absolutely. So I have some patients that have 5 different seizure types. So they might have one on a regular basis, like a daily event, and they have others that they might only have every couple months. So it's really important to know what your patient or client, what their seizure types are, because anything that's different is concerning. And we want the family to be in touch with us. or to know if they've had in the past a focal seizure that has turned into a generalized seizure if it's gone on long enough. So that's something to consider. Catherine was just giving more context to her patient that had the long seizure. That was the baseline, but it was a palliative case. So yeah, so I think in that case, they probably had multiple discussions with their care team that they're not going to bring them into the hospital every time. Because yes, obviously we wouldn't want someone passing away in transit to the hospital, but in a case where that wasn't their baseline and it wasn't a palliative setting, then yes, an hour-long seizure, definitely you're calling 911, you're getting them to the hospital. Any final questions from anyone? Okay, I think Stephanie's put a little feedback link in the chart if you guys want to complete that, but otherwise feel free. I know this recording will be available, and we're always happy to answer questions.
Yeah, thanks so much for joining, guys. I hope this was helpful.